thanks, of course, for being here. Thanks for taking your time to come and listen and to hopefully learn some things. We usually do these lectures in our office, of course, with the COVID and the crisis we're going through in the pandemic. We've had to change that, but we're really thankful for the technology that allows us to come together so that we can still get the information out to folks and hopefully more safely than gathering together, but allows us to get that information to you and to those that need it. A lot of folks have asked us about our office itself and how we're doing. We're remaining safe, of course, in the office, and one of the things we're trying to do is adhere to those CDC guidelines, and this is part of what we're doing here. We're wearing masks, of course, socially distancing and cleaning between every patient. Every room gets cleaned between every patient. And those high traffic areas, of course, gets cleaned more frequently. And every evening, the place gets sanitized so they're ready for the next day. All of our patient rooms are sanitized every night, as well as the x-ray rooms and MRI scan, physical therapy. All those are taken care of so that they're ready for the next day. We've also added some other precautions to help. We're doing some check-ins now from your car, so you can wait in your car. You don't have to be in the closed space of the office or in the waiting area. You can wait in your car. We've got an app that you can be checked in on. So that app, we can contact you while you're in your car and let you know we're ready for you to come into the office. You get taken directly from the front lobby there right into the room to see the physician or right to get your x-ray. So that happens so you're not sitting around amongst more people that's there. So we're trying to keep the numbers of people down. Every day our employees get checked. So we're making sure that we do symptom checks every day, so that the employees have to go through a special symptom check every morning to make sure that they're not a potential case of the COVID. So far, we've not had one in the office, so that's been good for us. We also offer telephone and virtual appointments, so patients get to be seen through this kind of technology that we have here on the Zoom, or through some of the virtual apps that we have in the office to be able to connect visually and be able to interact with patients, interact with their physicians, and see their images and go over the treatment options that are available to them with their physician privately, so that can be done either virtually, as we're doing here with the visual and audio, or also telephonically, to make sure that those patients are taken care of. For those who don't feel comfortable actually being or at a higher risk, those folks can do those virtual appointments. I think we're ready to get started with our lecture now. There is a Q&A box on your screen, so you can use that to ask questions throughout the lecture. If there's something that comes up that I don't cover, I'll try to get through those questions throughout the lecture, so you're hopefully we can move along and you can understand what we're talking about, and or if there's things that I didn't cover or didn't sound right or didn't make a lot of sense, just let me know through that question and answer box, so that we can answer those as we go. And if it seems to be a big question, we can stop and go over that specifically. But we're going to talk about treating some of the painful issues of the spine. And some of the things I think about, you put the ship in a bottle here, and some of the ways that we treat spine, especially surgically, we're doing a lot more through smaller and smaller incisions. So you think about the ship in the bottle, we're trying to make that ship, make that model, but going through a smaller and smaller hole, so that we're able to treat patients through smaller and smaller incisions and get their procedures done. But what are we talking about? Well, and anatomically, we're talking about the intervertebral discs. So the discs that are there, those are between the bones. So you can see the bones at each level is here. The discs are between. The disc has two parts to it called the annulus, which was on the outside of the disc, and then the internal portion there called the nucleus pulposus, kind of like a jelly donut, right? So the outside portion that's there holds that inner portion in its position, that jelly of the jelly donut. As we age, our discs wear out. This is an MRI scan looking at you from the side view. So the bones are the squares, the discs are between. As we get further down here between 4 and 5 and L5 and S1, those lower discs that are there look darker. They're not as tall as that disc that's up higher. That disc that's up higher here has more fluid in it, or more gray, more white. And that fluid that's there, kind of like think about a sponge. So that sponge has more water in it than the disc below. As the discs wear out, lose that water, lose its pliability, flexibility, and it starts to collapse, and more like a marshmallow. As that collapses, you get some bit of a disc bulge. So the disc bulges backwards into the spinal canal. And with that, you can start to pinch the nerve roots. The lowest one here, you see is bulged out a lot more, and that's actually a herniated disc. So the disc is actually ruptured out and pinching the nerve root there in the lower back. So that herniated disc is, again, the jelly donut analogy. The annulus has a little hole in it that the fibers of the annulus tear, and that portion of the nucleus then leaks out, and you can see it puts pressure along the nerve root. So it pinches that nerve root, giving that pain. So the pain from a lower back disc herniation actually goes down the leg. We call it sciatica. So pinching the nerve root going down the leg. That generally happens in the younger population between 30 to 50. As we get older, that disc wears, and as the disc wears, it becomes more fibrotic and less of that jelly of the jelly donut. So there's less material inside to actually rupture out. So those between 30 to 50 have more of that jelly, more of that cushion that's there that's actually be able to be ruptured out. And that fissuring or that tearing of the annulus allows that material to leak. The weakest part of the disc is actually on either side where the nerve roots are. And that's just how we are built. So that either side there where the nerve roots are is the weakest part. And that's where the disc can rupture, and that's why the nerve gets pinched. It doesn't have to be a big thing. We think about disc herniations maybe from car accidents or falls, that sort of stuff, but it can be a minor incident. If there's already some arthritis there in the disc and that annulus is a bit weak already, bending forward, picking something up, putting more strain or stress across the back allows that piece to rupture out and then pinch the nerve root. More broadly, rather than disc ruptures, or disc bulging. So the disc bulging is where the disc itself is compressed. Again, like the marshmallow, as it compresses, it bulges in the back and it starts to put pressure. So if we think about the spinal canal being a area like a water hose, so where the brain is at the top and sending information through that water hose, through the nerves down into the legs. If you start to pinch that water hose, that inflammation or that irritation that's there starts to pinch the nerve roots, so the information going from the brain down to the legs slows down. And that slowing down makes your legs tired, makes them feel weak and fatigued earlier than you normally would, because that information is slowing down. We do what's called a CT myelogram, or the myelogram portion we see here on the right side of the screen. That white that's in there is dye. So that's dye that we put into the spinal canal, and that dye you can see kind of gets washed, it gets pushed out of the way by the disc. So it's washed out in that area. So the disc is pushing that dye out of the way, indicating that there's pressure along the nerve roots into the spinal canal. One other condition we see in the spine is called spondylolisthesis, and that listhesis is actually a slippage of the bone. So the forward translation is slippage of the bones. As the disc wears out, the bones allow that to slide forward. And we see that this lowest level here. So the bones are lined up at the upper levels. The backs of the bones are lined up. The disc height is normal at each of these levels. This lowest one, the disc height is not normal. And you can see how that bone slides forward. As that slides forward, the area for the nerve roots, these little holes here called the neuroforamen, they get smaller and smaller, and they start to get pinched. And that's where the nerve goes down into the leg and it gets that sciatica, that nerve being pinched, going and giving the back of the leg pain down to the foot. One other condition in sort of stepping through that spondylolisthesis is a condition we call spondylolysis. Spondylolysis is actually a crack in the bone. So if we look at this picture, the top right here, that area where that's red, that's where the bone has actually been cracked. So that separates the front of the bone from the back of the bone. And as the disc wears, that allows it to slide forward, that listhesis, we call it the spondylolisthesis, that slipping forward there of the bones. And it's a similar problem. As that slips forward, it starts to put pressure along the nerve root, and you get pain in the sciatic nerve going down the leg. The anatomy is very similar in the cervical spine. The big difference in the cervical spine is that the spinal cord is there. So the spinal cord in the back, the bones in the front, and the disc between the two bones. So as the disc wears, you can rupture the disc and pinch the nerve root, similar sort of thing as before. You pinch the nerve root and it gives you, in the neck, gives you arm pain, numbness, tingling pain going into the arm. Very specific distributions of the nerve. The C5 nerve goes down to the thumb, index, and long finger. The C6 nerve goes down into the small and ring finger. So there's specific nerves at specific distributions going down to the arm. And what that looks like on an MRI scan, this is from the side view, again in the neck, the brain's at the top, so we know this is the neck here. As we get down to the red arrow there, the disc at C6, 7 is pushing back, and that's into the spinal canal, into the nerve root. From the top down, we see that a bit better, and that red arrow again sort of pushing across the nerve root there on the left side, and that's pinching the nerve root going down to the 6, 7 level, to the small and the ring finger. And we'll know this on that left side. So very specific distributions of pain related to which level. So most of the times when the physician is examining you and trying to figure out where the pain is coming from, we can have a pretty good guess at which level is being bothered, because we know the distribution of your pain and the expected distribution of the nerve roots in your neck or lower back. So after we do the physical examination and we kind of know what we're looking for, then we get some x-rays. So the x-rays themselves, we do plain x-rays, and that's to look at the bony alignments. Are they shifting? Are the bones moving? We saw that spondylolisthesis, that slippage of the bones, or the spondylolysis, that crack in the bone. Those are better seen through an x-ray study than they are through further imaging studies like MRI scans. Now, the MRI scan does give us good information about the nerves and the discs and the bone marrow, gives us some information about bony alignment, but it's really more specific for the soft tissues. It gives us good information about the discs and the degeneration of the discs and what's affecting the discs. There's that study we just saw called the myelogram. That's where we put the dye into the spinal canal. We can see the outline of the disc pinch the nerve roots. We call that spinal stenosis as the disc pinches through there. Discography, that's where we put some dye and some medication inside the disc itself. And that's a very painful procedure, really done for determining if the disc is causing the pain. And why is that? Well, we get lots of information on MRI scans, CAT scans, x-rays, and that gives us information, but it doesn't define the pathology. So we use the physical examination, we use the imaging studies, we put those together to help determine where the pain is coming from. About a third of patients will have an abnormal MRI scan. So I see lots of patients that come in and see me and say, well, I just need an MRI scan. Well, the MRI scan is just part of the story, because lots of patients will be asymptomatic. So about a third of patients with no problems whatsoever will have an abnormal MRI scan. So the MRI scan itself isn't diagnostic for that and telling you the pathology, but putting all that together, the physical examination and the imaging studies, so we know, have a better handle about where the pain is coming from and then what we need to do about it. So what do we do about it? Well, the treatment for that, basically we start what we call conservative treatment. Treatments that include bed rest, a couple of 3 days, letting the muscles relax, letting the inflammation die down, using anti-inflammatory medications, some medications to help decrease the irritation, the inflammation around the disc, around the nerves, the arthritis, the muscles and tendons. Analgesics that we use for things that are more acute, so increasing the quantity or the effectiveness of larger and more detrimental medications like opioids, those sorts of things. We don't really use those until it's really bad. Antidepressants or muscle relaxers we use to help decrease the irritation, inflammation that's there around the muscles, help to slow that down, stop the irritation that's there in the muscles themselves. Braces, we use braces early on. It's not a long-term treatment, but it's something early on to help the muscles relax, help you get up and moving because the muscles are irritated or painful. Long-term diet, exercise, things that help decrease the irritation, inflammation, and pain. Now, most of the people are going to get better. So the conservative treatment route generally gets patients better. and pretty well back to normal. This is a study here looking, we call natural history of sciatica related to a disc herniation. In the bottom corner here, you see that 65% of patients got better in 2 weeks with conservative treatment. So doing the bed rest, the anti-inflammatory medications. About 87% of patients are better at 12 weeks. So within 3 months, feeling much better, pretty well getting back to normal. So with the natural history of the sciatica and the disc herniation, most people will get better. Now, long-term bed rest, it really isn't any good information that says a long-term bed rest or enforced bed rest is efficacious, is going to make you a lot better. But taking some rest, taking some time off, getting the back to relax, those sorts of things are will help you improve. But we really want you up and moving as much as you can to keep the muscles and tendons working like we should. Bracing. So bracing itself doesn't help with prevention. There's really no evidence that it's going to make you not have back problems, but we do use it for treatment. So symptomatic pain control, things to help stop the irritation, inflammation. So if you're taking a short trip down to your new house, you can duct tape some stuff on the roof and you're going to be okay. But if you want to take a longer trip, you have to have something that's going to treat it. How about medications? So medications, as we talked about anti-inflammatories, this is actually from 1996, when even before this, the opioid crisis that we talk about now, this was in this study that looked at acute lower back pain and the guidance for that. And if you see at the very bottom, it says avoid the narcotics, and because the anti-inflammatories, the non-steroidal anti-inflammatories are just as strong, just as potent as the narcotics are for back pain. So we try to really avoid the downsides of taking stronger pain medications like opioids. So using the anti-inflammatories and muscle relaxers help you through that. And we see within 2 weeks, should be feeling a lot better. How about physical therapy? Yeah, physical therapy works, helps to massage those muscles, get things loosened up, stops the spasms and pains. And that can be done in several different ways. We call booklets. That's basically the doctor giving you a booklet to say these are the exercises to do. Chiropractics, of course, and physical therapy specifically. Chiropractic is very good. Physical therapy, very good, because they can work on you, right? They can help you through this, give you some encouragement, work through the process, and help you feel better as you go through the process itself, rather than just giving you a book and say, hey, do these exercises. They're there to help guide you through that and get you feeling better. And they can alter treatment as you go through. So both of those very good. We know the combination of chiropractics, exercise, and modifications of your activities of daily living, 65% of these patients back in the study 2006 actually got a lot better within 2 to 6 weeks. So feeling a lot better, getting the pain, the inflammation better, loosening things up and getting back to normal. Traction gets done in chiropractic and physical therapy, so that the traction being done helps decrease the muscular spasm, right? Pulling on those muscles and tendons, getting them to loosen up, getting them to relax, doing those stretches to help things move along for you. So helps a lot of that spasming happens and gets your pain much better within a couple of weeks. Now we know that that's part of that conservative treatment, right? The conservative treatment gets you better within a couple of weeks, feeling a lot better by 3 months. When all that stuff fails, that's when we talk about surgery, right? So surgical management of this, we have several options on that. We'll talk about all of these, but the main one is called laminectomy. Laminectomy is done for nerve problems. You do a laminectomy for what we call neurodecompression, taking the pressure off the nerve roots, opening that space. Just as we talked about the water hose being pinched, we want to unpinch that by doing that laminectomy, decompressing the nerve roots. Fusion is another option in surgery. So fusion, we do that for instabilities. The bones are shifting or moving where they're not in the right place. Then we put in screws and rods to hold the bones in position. Now, these are done really for instabilities and for nerve problems. They're not done for back pain. The back pain specifically is somewhat inconsistent for surgical things. So we try to keep you out of the operating room if you're thinking about surgery for back pain. That's really way down the list of things to do. We've got a lot of other conservative things to do prior to getting to an operation for specific back pain. Nerve pain, surgery is generally the right thing to do. So after all those non-operative things fail, that's when we think about surgical options. What is a laminectomy? Well, if we look here at this little picture on the left side here, the laminectomy is removing the lamina. That's a bit of the bone that's here. We call this the spinous process. The lamina is that red line on either side. We're basically removing that lamina on either side, opening up that space so that we can get down to where the nerve roots are. We see the intraoperative view here on the right side, the spinal canal, the dura, which is that sort of faded out gray area through there. Just to the left of that, that's where that nerves are being pinched. So they've got that piece that's pinching the nerve roots. We want to get that out. So we've done the laminectomy, open up that space. This is why we're here, to get that big piece of disc herniation out from around the nerve root and open that space up. Decompression works. So we think about decompression for disc herniation. There's multiple studies out saying decompression for disc herniation, removing that disc. Surgical treatment is much better than non-surgical treatment. It gets you better faster, as would be expected. Taking the pressure off the nerve root is better than leaving the pressure on. Spinal stenosis is the same thing. That pressure around the spinal canal. We want to take the pressure off, open up the nerve roots so that the nerve roots can function. If we think about that, the water hose as well. So taking the pressure off the water hose allows that information to flow, allows the water to flow down the hose. So it opens up that space so your legs start to function like they're supposed to. How about laser surgery? I get a lot of questions about laser surgery. When we talk about surgery with patients, they want to know if this surgery is going to be done with a laser. Well, laser surgery, and what that's really implies is you're doing something through a small incision. You see the picture of the guy here. He's got the little Band-Aid on his back. Thank you, laser spine surgery. Basically what they're doing is putting a needle into the spine. They can insert a scope into the spine and see the disc, see the pressure along the nerve root. Using smaller and smaller holes, they can use a laser. They can use something to burn the nerve, to cauterize the nerve, the disc around the nerve, so it takes the pressure off the nerve root. They can add a cortisone injection, we call an epidural steroid injection, something we do at the office here, or what's called radiofrequency ablation, which is basically burning the nerve roots around the facet joint, the small joint in the back, so that that joint doesn't have any sensation and you don't then have pain related to that joint. Unfortunately, laser spine surgery went out of business in March of 2019. It was found to be basically a marketing gimmick. So all the stuff that you see here, endoscopes, laser, cortisones, radiofrequency ablation, that all gets done in our office now. So what laser spine surgery was doing was basically upcharging for all of that stuff and making you pay cash and not going through your insurance. So they went out of business. When it basically was turned out that all the stuff that they were doing is covered by insurance at your local spine doctors. What about fusion surgery? So we talk about fusion surgery and everybody gets scared about that, but fusion surgery itself is putting in implants, putting in screws and rods, basically to hold the bones together until they fuse. Fusion itself is your bones growing together. We think about a broken bone. You break a bone, and with time, the bone cells heal. The bones heal back together. And what we're doing into the spine is we're basically creating a controlled fracture. We're shaving the bones, taking the cartilage out of the spaces around the bones, and then we add the screws and rods that act like an internal cast, or like a broken bone, we put a cast on. So these screws and rods act as an internal cast for the bone to allow the bones to heal together in the position we want them to heal. So it's basically holding it there. When do we do fusion? Well, fusion has specific indications, right? So indications of spondylolisthesis. When the bones are slipping or moving, we don't want them to slip and move. That's what's causing the pain. So we put screws and rods in to prevent that, to keep those bones in position and then allow them to fuse in the right position. Scoliosis is one of those other things. So if the bones are twisted or curved, the spine is twisted or curved, we want to try to straighten that out. So we put screws and rods in there to allow us to do that, to hold the bones in position so that they stay where they're supposed to be, and then they can fuse together in the right position. Thinking about that cast, right? So putting the bones in the right position, putting something on there, a cast in, say, an arm fracture or leg fracture, holding that in position till it heals. One term we use is called iatrogenic destabilization. What does that mean? Well, that's actually when we're in the operating room and we find that there is not enough bone to hold the bones in position. So especially in patients that have had a previous surgery, recurrent stenosis, or a second-time disc herniation at a certain level, they've had a previous surgery and the bone has already been removed at that level. If we're going in to do that same procedure again, we're going to be removing a bit more bone, and that may create the bones to be unstable. And if that happens, we need to hold them in that right position. So we put screws and rods in there to hold that in position so the bones stay where they're supposed to be, and then we can allow them to fuse. But there's a lot of fear around surgery, right? So we think about surgery, and patients that get concerned about surgery and think about the size of the incisions. We're going to have these big incisions, big scars on the back, pain from the surgery itself or pain after the surgery, and how much time off of work do I need? The risks of surgery. I hear a lot of people asking about paralysis and nerve injuries and infection and bleeding, all those sorts of things. Those are all risks of surgery, of course. Need for another surgery. So the friends have told me I've gotten a previous surgery, I didn't get any better, or I need to have another surgery. So lots and lots of fear around surgery itself. So take heart that actually of the 56 million patients that have back pain in our country, only 5% will need surgery. So 95% of patients that have back problems or have nerve problems will not need a surgery. So that's a good percentage. So most patients are going to get better without surgical treatment. They talked about the medications, the therapies, the exercises, those sorts of things are going to get you better. There's only a few small number of patients that actually will end up needing surgery. When we think about surgeries themselves, we've actually come up with a technique that we use. It's called LESS, or less exposure spinal surgery. And we've developed that really around the patient's concerns. So those types of things with patients that are concerned about their surgery, we're trying to get those patients to back to their normal state. So we're trying to get them to back to their normal surgical, using the surgery to get those same goals that we do through an open surgery that may be much more painful, but trying to decrease that pain related to the surgery, improving the function post-surgery, as well as returning to that normal function more quickly. I hope that's making sense. We'll talk about a little bit more here, but when we talk about surgery itself, if you have questions, just put them in the box here and we can talk about the questions you may have so we can address those as we go through, but or at the end. So when we talk about surgeries, we've got a lot of innovations, right? We talk about surgery being in the lumbar spine and cervical spine. We're doing most of these surgeries now as outpatients. What does that mean? That means you're going home the same day. You're not staying in the hospital 3 or 4 days, or back even when I was training 20 years ago now, that was it was consistent that patient would stay in the hospital 5 to 7 days after they had their lumbar spine surgery. Now these patients are going home within a couple of hours. The surgical techniques have better, the better pain control after surgery, and getting back to work, back to sports, and no restrictions at all. There was a time where, especially neurosurgeons would say you'd have to have back surgery and you couldn't lift more than 20 pounds for the rest of your life. The idea behind surgery, especially when we think about orthopedists doing surgery, the idea is to get you back to sports, back to life, back to the things you want to do as quickly as possible. So LES, so the less exposure spinal surgery, meets the same surgical requirements. We're trying to decompress the nerve roots, take that pressure off the nerves, as well as provide the bony stability. So if the bones are shifting and moving, we want to be able to add the screws and rods, but all do through smaller incisions, so less trauma related to the surgery itself. Because of that, the pain control is better and the patient can go home that same day. So what does that look like? Well, this is a standard procedure for a 2-level surgery here on the left side. See, in the middle here is called a laminectomy, right? We remove that lamina we talked about, and that's down that gray area here. That's the spinal canal and the nerve roots. Add the screws and rods. That's a 15 centimeter, we call open procedure, the standard normal open procedure we do. There has been some innovations and we call minimally invasive, or MIS procedures. And what does that mean? Well, we make smaller poke holes on either side to add those 3 screws. Underneath this ruler, unfortunately, is also a 5 centimeter incision. So we can add the screws and rods from the side, but we can't do the decompression. We can't take the pressure off the nerve roots through those same little incisions on the side. So we have to make a smaller incision in the middle here, so a 5 centimeter incision there. The LES procedure is actually done through the middle. So we'd make that 5 centimeter incision and we do all that same work, do the decompression, put the screws and rods in all through that same incision. So decreasing the trauma, decreasing the surgical time, decreasing the exposure, and what we beat you up basically in the operating room, moving the muscles and tendons around that causes pain, decreasing that pain related to the surgery itself. Those wounds are much smaller. You can see we've got a much smaller incision here, putting in bone graft on this side on the right side, lots of screws and rods. And this is through a minimally invasive. So these are the poke holes where these screws go in to the smaller incisions, but adding that all up, it actually ends up being a much bigger incision. This is what that looks like, an open procedure where we put the screws in. So this is on the left side here, the screws going from outside to inside. And that's allowed, that's a normal procedure that's there. And then we do some decompression, take the pressure off here. On the right side, you can see the screws here at a different trajectory, right? They look like they're going from the inside towards the outside. And we see that area in the middle here, that's where we've done the laminectomy. So opening that space, taking the pressure off the nerve roots, and then the screws and rods get added. So it allows us to not have to open up the spinal canal, the muscles around the bottom here very much. So we're able to put those screws in through a much smaller incision. This is a more drastic example of a less exposure surgery. So this is a patient here at the bottom where we've made an incision to get to their thoracic spine. So we've taken out a rib, we've moved the lung. So the lung is behind this little spatula here so we can get down to the spine. And take the disc out and put the screws and rods in. This upper one is done through 3 small poke hole incisions there. We use an endoscope to get in there so we can see what we need to do and then put the screws and rods. Again, similar procedure. We're taking out the disc, mobilizing the bones, and then putting in the screws and rods. The standard open posterior procedure is this long procedure here. We're putting in screws and rods, taking the pressure off the nerve roots, and a very long incision. That's all through the back of the spine. So again, going from that big incision all the way down to those 3 little poke holes. And this is what that looks like after surgery. The patient here on the left is the one that had that endoscopic procedure, taking the discs out and then adding the screws and rods to hold that all together and then straightening out the spine as we go. In the neck, we have limited exposure surgeries for the neck as well. So we're going to take out the disc, which is the gold standard, removing the whole disc, taking the pressure off the nerve root. So if we're looking at this little cartoon here, the disc is ruptured out, and that's more central. So in order to get there, the spinal cord is the back. So we try to get there. We can't really go for the back, so we go through the front and take the whole disc out. And this is what that x-ray looks at the end. So we're going through the front, we've taken the whole disc out, put a bone graft and plate there to hold everything together. So surgically, this is in the operating room, we're going through the front, making that small incision on the front of the neck, and that's the disc material that's there. So we're going to remove that whole disc, take out all that cartilage material that's in through there. That allows us to work from the front to the back, removing all that material so we can get to that disc that's in the back there that's pinching the nerve roots. And this is what that incision looks like. So here from the side, little cartoon, you can see the incision that's there. And on the right here, that's what this lady's incision looks like 3 months after surgery. It looks like one of the natural skin lines there on the neck. So that makes sense. If not, just ask a question. We'll be happy to answer some of those questions as we move along. So LES, less exposure spinal surgery, smaller scars, less pain, all done as outpatient procedures. So the neck surgery takes about 45 minutes to an hour. Go home that same day. The arm pain goes away within the first 24 to 48 hours after surgery. Improving function, right? Getting you up, getting you moving. So you walk out of the hospital, you're not laid up after this, and back to work. So in the neck surgery, pretty well back to a light duty at work at 10 days and back to full duty at work at 6 weeks. Lumbar spine is very similar, back to light duty at 2 weeks and back to full duty at 6 weeks. After 6 weeks, there's no restrictions. We want to get you back to the full activities you want to do, back to your normal activities. That's really the goal behind getting this done. And through the less exposure surgery, we really want to make it less painful so you feel like you can get up and get back to your normal self much more quickly. I don't know if any of you are circus performers, but this fella here is kind of the idea behind that. He's a horse rider. He's a guy that's on the horse. That fellow there, he was part of the Ringling Brothers circus, and he came from New Jersey. He had ruptured a disc in New Jersey, and he came down. He was playing at the Coliseum here in Hampton, and he came down and see us and said, you know, I can't perform. I can't go on with this. What can we do? So we looked at his MRI scan, a very large disc herniation, pinching his nerve root. So we went to do surgery that next week, took the pressure off the nerve root, did a 2-level fusion, putting in screws and rods to hold that in position. And then after surgery, he sent me this video of him performing, if I can make that happen. Maybe we can make it happen, maybe we can't. Technology is awesome. Anyway, he's on the horse, so he's an acrobatic horse rider. He was at 6 weeks. He was able to get back to his full activities and back to riding the horse again. He sent me this video 6 weeks after his surgery to say thanks for allowing him to get back to his life and back to his work. So I hope this was helpful to you. I hope that we've made things clear, and really just not to be fearful of surgery. There have been lots and lots of techniques out there that have improved, and we've gotten our surgical techniques to be able to get patients back to their normal activities much more quickly than we have in the past, and being able to do that as an outpatient procedure. The fear of COVID, of course, and that's kind of led patients to come more to the outpatient side to be able to have surgeries that are done in an outpatient setting. So that they're able to not be in the hospital where the potential exposure is there for the COVID and for the viruses there, recovering at home and getting back to their normal activities much more quickly. So if there's any questions, things I can answer for you, please let me know. A couple questions here. So one is asked, if I needed surgery, where would my surgery be? Well, the surgeries that we're doing now are mainly outpatient surgery. So we're doing a lot of the outpatient surgeries that can be done at either the hospital or at the surgery center. Currently in the early stages of our surgery center opening, so we're not quite ready to get that started yet. But all the outpatients and inpatients are being done at Mary Immaculate Hospital. It's actually the #1 hospital in the state for spine surgery and spine fusion surgery as far as safety is concerned. So the best place in the state to get that done. So right now, that's where we're doing our surgeries. With time, we're going to be moving those over, lots of them over to the surgery center from an outpatient standpoint. Let's see, I've enjoyed running and chasing after my grandchildren. If I were to have LES exposure surgery, how long until I can get around to chasing them around again? Really depends on how old you are, I guess. But the surgery itself depends on what type of surgery, of course. But as we talked about, the neck surgery, lower back surgery, pretty well back to normal by 6 weeks. So we really want you to get back to the normal activities, the things you enjoy doing. Right, to get those questions. So if I have a fusion surgery, I won't be able to bend my neck or won't be able to bend my lower back. I can't bend over, tie my shoes, or gardening. And that's really not true. The surgery itself is done around discs that aren't moving very well to begin with. So the surgery to fuse those should be less painful after surgery. So you'll be able to get back to normal motion and function with less pain. So if the pain is what's slowing down your motion, we would expect your motion to be better after surgery and after you get fused. So thank you all for joining us. If you have any further questions, we'll be happy to entertain those. You've got our office number at 757-596-1900, or you can go online to our website at www.osc-ortho.com, or you can email us at lectures@osc-ortho.com.